you very much. My presentation was intended to be a just case presentation as an illustration to the previous lecture. So a few words how we did our patient. The patient was 82 years old gentleman who presented to regional hospital due to pulmonary edema and non-STEMI with ejection fraction 12 measured in echo. That was the first presentation of coronary heart disease in this patient. Patient was never treated for any cardiovascular disease before, just penis cancer treated 10 years ago successfully. And I move forward. Oh yes. And they in the regional hospital performed coronary angio. Right coronary was occluded without any possibility to reopen it, which was later confirmed by experienced CTO operator. And the bifurcation of left main and LAD was involved, as well as the ostial left main. So patient was sent to our institution to check viability of the left ventricle, and despite of some segment of the basal, middle and anterior part of the interventricular septum, everything was viable. So patient was sent to the heart team with Medina 111 in left main and diagonal LAD diagonal 100 probably, and the heart team qualification was to PCI with left ventricular assist device. So my strategy was to avoid two-stent technique if possible, because patient has very low ejection fraction, what means very high thrombotic risk in this patient, and keep, of course, everything open if possible. So first we started with checking what is really critical, and we found that unfortunately diagonal branch and circumflex artery were critical. So we started with orbital atherectomy, because I believed that removing the plaque will help me to decrease the volume of the plaque at the ostium of the diagonal branch and circumflex artery. So probably I will not have to stent these two arteries. After that, we performed the OCT, which revealed widely open circ and widely open diagonal branch. However, in some places, this calcium was not cracked properly, which you can see here with non-properly opened balloon during the predilatation. So we had to escalate to intravascular lithotripsy, and now you can see very nicely cracked everything in this LAD. So we sized the LAD and sized the left main in the OCT and put the Science Sierra stent to LAD as well in the left main, post-dilate with 5.0 balloon, which was even oversized, kissing, and then again 5.0 post-dilatation. This is the worst angio after this stenting. You can see some disease in the circumflex proximal. So we put again the wire that was on the table, and you can see, unfortunately, 0.73. So we had to stent this circumflex ostium and proximal part of it with the same wire. So again, kissing, again, repot, and OCT showed that we covered the ostium. We also properly opened this stent. Also in LAD, it was nicely opened, the stent, and OCT showed that the ostium of the circumflex was widely open. So we checked the LAD and we checked also the circumflex, which showed that DPR was almost 1. However, I was not able to rewire the diagonal branch, and at this point I decided not to close it. And that was the final result of this procedure. Because there is completely no correlation between coronary angiography and the functional assessment of bifurcation lesions, and there is strong correlation between FFR and especially in the prognosis, correlation of the prognosis with FFR, especially in the circumflex artery, jailed circumflex artery. So it is really important to use the physiological assessment of the bifurcation. However, this case was to show the balance between the indication to reopen or to open small arteries and the further risk of the complications like the stent thrombosis. Thank you for your attention.
Yeah, thank you. Very well done case. How was improvement of LV function? Did you observe some improvement after revascularization?
Not yet. Patient was not released from our hospital yet. It was 5 days, no, maybe more a case, 10 days case.
So, thank you so much for this extremely updated case. There is some question also from Mila.
Okay, thank you for a great presentation and a great case. I was wondering, maybe this would be the straightforward case for the off-pump Limalad, for example. It's 12% ejection fraction, and as you already performed the coronary physiology, maybe it would be like the nice case for very skilled surgeon like Limalad.
But the patient is 82.
82. Okay.
How many surgeons operate 82-year-old?
Okay,
in my hospital, no way. So just by hand, how many in your surgeon are operating at 82? Okay.
Yes, in our hospital, when you ask...
5% of the total. Okay.
But
okay.
Yeah, I agree. I didn't.
With the 22% of LVF and 82, I mean, I think it's very. I mean, I would love sometimes. Yes. I mean, they refuse even. Much better patient, even 50-year-old with 22%.
Sometimes they operate patients even older, but not with so low ejection fraction.
Anyway, I didn't notice the age of the patient. However, you performed 3 DPR. Yes.
Yes.
LAD, circumflex, and the diagonal. But the diagonal is going to be influenced also by the proximal LAD and the left main. So maybe the DPR from the diagonal is not so useful at the beginning. Yeah. Do you agree?
Yes, I agree. And there is no slide because the intention was to be short. However, in OCT, there was widely open the ostium of diagonal branch. But unfortunately, after stenting, I was not able to rewire it again. So
no, of course, I agree with the technique, everything, but just the DPR from the diagonal maybe was, in my opinion, humble, unnecessary. That's just was my point. I
mean, anything has to be adapted entirely to the patient. This is a patient coming with a pulmonary edema, non-ST elevation MI. I mean, and that's the point. Do you have a threshold of age, for example, for Impella? Because again, 82, honestly, even if we are the larger user in Italy, one of the largest in Europe, 82 would be a cutoff for us. I mean, we don't implant Impella more than 75 usually. So that's interesting. Do you have a cutoff of age, or indeed it's the clinical indication of the patient? You evaluated well the vascular access?
Well, if the survival is longer than 1 year, we believe that it is worth to revascularize. The same situation is with TAVI, where we use, because I understand your point about the vascular complications. However, in TAVI, even we sometimes use bigger bore puncture.
But that's an elective procedure. This is a urgent procedure. So elective means you did a CT scan, you evaluate the access, and not
Yes,
all
do.
the 82 are treated, are the ones that are feasible for treatment. So did you check for the vascular? Did you do a CT scan on this patient?
We do. I was not presenting it here, but we, for all the patients, we do CT scan. If there is no access in the iliac arteries, we go through axillary.
A comparison with TAVI is extremely correct, I think, because there we spend much more.
No, but that's an elective procedure. This is an acute, so sometimes you don't have time to do all this.
Yeah, I will end this session with a joke, but it's a new I would say, recommendation from the EBC. When it's simple, you do provisional. When it's complex, you do decay crush. When it's a catastrophe, very complex, you do provisional. Thank you.
Still?
I'd probably like to close with his statement, but I have that extrapolating on Alaide's comments, extraordinary case. I'm not sure about the appropriation of funds, at least in our setting. This would be way, way, way too costly. I mean, I don't know if this is something that you can afford. We certainly cannot.
The major issue was the impel, I think. But without an impel, this procedure could not be done.
No,
Would
definitely.
agree. Also, Aida could agree.
No, I mean, we cannot say it could be done. I mean, I'm a believer, clearly, but we don't have the data that says it cannot be done. So by our personal experience, we will feel, let's say, much more comfortable to have an impel on board, but we cannot say we can be done or
but
not.
Randomized study, PROTECT 4 studies ongoing, so we will have data in the future. Thank you so much,
you.
Stanislaw.